Great. Okay. So welcome everybody. I am very excited to be here today. Thank you so much for having us. Thank you to the Mirage JCC and to Jerry for putting this together. And I just want to thank our speakers who you're going to hear throughout the program. Suzanne, who's going to be sharing her story, Dr. Smith, who's going to be talking to us about our health, Bita, who's going to be educating us about genetics, and Susan Fox, who's going to be letting us know about this new City of Hope in Orange County. So I'm really excited to share it with you. We all know that this has been a really hard year for so many, but I want you to imagine being back into April 2020 when we were all locked down. Maybe your kids moved back in with you, or you had kids home from school. Maybe you were doing all of this when you were trying to work from home. Now imagine going through this past year and getting a call from your doctor saying that you had been diagnosed with breast cancer, that you couldn't have your spouse sit with you during chemotherapy, that your surgery was delayed because of a diminished PPE supply. You were immunocompromised and had even more reason to fear COVID. And that's when you learn about Sharsheret. So Sharsheret is the Hebrew word for chain, and we're a Jewish nonprofit organization started by Rochelle Shoretz, who was a young Jewish mother from New Jersey diagnosed with breast cancer at the age of 28. She had been a clerk for Judge Ruth Bader Ginsburg in the Supreme Court. She was a powerhouse. And when Rochelle was diagnosed, all she wanted was to connect with someone like her who was going through what she was going through. And friends introduced her to another young Jewish mom who was a few months ahead in treatment. And that's how Sharsheret was born, around Rochelle's kitchen table. This year, we're celebrating our 20th anniversary as a national organization with offices in New Jersey, New York, Illinois, Florida, and here in California, with a staff of about 34, including social workers, a genetic counselor, and outreach professionals like myself. Sharsheret's mission is to improve the lives of all women and families at all stages or at increased genetic risk for breast or ovarian cancer through personalized support and educational outreach. We share resources with women and families so that they can make informed decisions about their health and treatments. And we also help the next generation by working with students on high school and college campuses to understand their risk and their family's health history. And additionally, Sharsheret educates community leaders and healthcare professionals about the unique issues for Jewish women facing cancer so that they can better care for their patients. Sharsheret's programs are free and open to all. About 25% of the people that we support are not Jewish, and we don't turn anyone away. So you might be asking yourself, why do we need a Jewish organization? And the reason is because 1 in 40 Ashkenazi Jews carries a BRCA gene mutation. And that's nearly 10 times the rate of the general population, which makes members of our community significantly more susceptible to hereditary breast cancer. And since both men and women are carriers of this dominant genetic mutation, there's a 50% chance that a carrier is going to pass that down to their children. And we also need to be aware of other gene mutations like ATM, CHEK2, PALB2, and those associated with Lynch syndrome. Being a carrier of these or a BRCA1 or 2 mutation puts you at increased risk for cancers, including breast, ovarian, male breast, prostate, pancreatic, colon, uterine, and melanoma cancers. And I know Bita's going to be talking more about this in her presentation, but it's definitely worth mentioning here as well. So I just want to stress to everybody, especially those with Ashkenazi Jewish descent, how important it is to know your family history for men and women. Ask your parents, your grandparents, your aunts, uncles, any living relative, were there any cancers in the family? Mental health issues like depression, high cholesterol, heart disease? At what age, what kind? And I encourage you to also share this information with your children so that they can be informed when speaking with their doctors. And if you have questions about your own family history and what to make of the information you gather, Sharsheret is here for you. So is our genetic counselor. So one of our callers learned that they were a carrier of the BRCA gene mutation through her dad's side after he was diagnosed with prostate cancer. She'd been struggling for 10 years with what to do about it, whether to get preventative surgery or continue with surveillance through mammograms and MRIs. And she asked that question, is knowledge power or is ignorance bliss? Because she felt wedged between both. And that's why Sharsheret is here to help. Our peer support network connects women who are newly diagnosed, survivors, or at high risk with others who have faced similar diagnoses and experiences. We also sent out free kits to help support women and their families at all different stages of their treatment. For example, we send out a Best Face Forward kit that includes non-toxic and paraben-free makeup and eyebrow stencils for women experiencing the cosmetic side effects of cancer. And our kits are tailored to each individual who contacts us. All of our support is and always has been virtual: phone, email, snail mail. So we didn't have to do much to change with COVID. The one difference we did make is that we've been doing weekly webinars on a variety of topics with experts from all over the country. And you can find those on our calendar, and our past webinars you can also see on our website at shareshare.org. So now, only 10 to 20% of breast and ovarian cancer is hereditary. So it's imperative to remember that 1 in 8 women will be diagnosed with breast cancer in their lifetime, and 1 in 72 women will be diagnosed with ovarian cancer in their lifetime. This means that all of us should be paying close attention to our bodies, commit to a screening plan that's right for you, and be healthy in our daily lives. Eating healthy, moving more, reducing risk, reducing stress, all essential to reducing risk. This year has been tough, and I know taking care of ourselves has been easier said than done, even pre-COVID. But since the pandemic began, fewer people went in for routine breast cancer screenings, leading to later detection and more advanced cancers in women. So if you're of the age where you need a mammogram, or somebody in your life is, please get that rescheduled if you haven't already. We know how easy it's been to delay, but whether it's your mammogram, your checkup, a genetics consultation, please make sure you're staying on top of your own health. If something doesn't look or feel right, don't put off calling your doctor, because it could save your life. And finally, now that you've heard all of this, you are our new Share It ambassadors, links in our chain. This may not feel like a real important moment, but in 5 days, 5 weeks, 5 months, or even 5 years from now, you may run across somebody who's been diagnosed or have a loved one who has breast or ovarian cancer, or someone's discovered that they have a genetic mutation. And you'll be able to say, oh yeah, I went to that presentation, I heard about Share It. And that might make a huge difference in their lives. So I encourage you to check out our website at shareshare.org. We're on Facebook and Instagram, and I'll send all this information to Jerry so that she can send out a follow-up email. But please follow us, because it really does make a difference. So thank you for joining us today. And I'm going to turn it over to Suzanne to share her story.
All right. Hello, everyone. So my name is Suzanne, and I may fool you all because I'm young, I have a head full of curls, I'm healthy, I'm fit, but I had breast cancer, and I had it when I was 32 years old. So this was 8 years ago. And I perfectly remember that morning of August 14th of 2013, when I got that dreaded phone call saying, you have breast cancer. And so let me rewind for all of you. I had a 16-month-old baby boy at the time, and I knew that I had the BRCA2 mutation. So you ask, is knowledge power or ignorance bliss? I'll tell you, knowledge is power. Why? I feel that my knowledge of having the BRCA gene is what saved me, though I wish I would have done things differently. So back, I have a family history of my grandmother and great grandmother had breast and ovarian cancer and passed of cancer when they were young. My mom and my aunt tested for the gene when they were young and found out that they had it, and they did prophylactic mastectomies, prophylactic hysterectomies before it was like, you know, the popular Angelina Jolie way to do it. And I decided that I wanted to know if I had the gene out of college when I was 23. So this was way before it was like the thing to do was to test young people to see if they had the BRCA mutation, but I wanted to know. For me, knowledge was power. And so I tested, and I became part of the Gilda-Radner studies, which now allow breast MRIs for people who have breast cancer, genetic mutations. So I was being watched so carefully. And my goal was I was going to go and have my family by 35 so I could do prophylactic everything at 35. So I was on like my mission, right? So I went, I got married, I had my first child, I breastfed for the year. And as soon as I was done breastfeeding, I said, okay, it's time for me to go and get my screening checks, because they had been on hold because of the pregnancy and the breast cancer. I'm sorry, the breastfeeding. So I went to my doctor, and she said, nope, you feel good, but you should go get that breast MRI because you're due for it, right? normally, if I didn't know that I had that BRCA gene, I would never have been told to do that breast MRI at 32 years old. Well, that MRI is what saved me, because that MRI is what found the cancer. And that cancer was really small. It actually took 3 ultrasounds for them to find it, 3 ultrasound technicians before the doctor walked in, and she said, I'm going to find it, for them to find it. So it was that small, but it had gone to one of my lymph nodes. I went through chemotherapy. I went through double mastectomies and reconstruction, 33 rounds of radiation, a full hysterectomy, and oophorectomy. And I'm thrilled to shout that I am cancer free, or no evidence of disease, NED, whatever you want to call it. I'm healthy and I feel great. But I tell people all the time that it's really important, if you know that you have a family history, ask your families, just like what Jessica said. Because if I did not know that I had my family history and that I had that BRCA mutation, I would never have been screened correctly. And I would have had a whole other pregnancy. What would have happened during that pregnancy for that estrogen driven cancer? I don't even want to think about where that cancer would have gone, for me to have found it later on. In fact, one of my doctors thought that it would have taken me about 5 years for me to feel that cancer on myself, if I did not have that MRI. So I am a huge proponent of asking questions, finding out if you have a gene, and then deciding what's best for you, whether that's surveillance, like what I did. But I always tell my breasties, okay, I have a lot of breast friends. My husband calls me the cancer concierge. I talk to new moms diagnosed with breast cancer all the time, because that's what helped me through my journey. And so I'm able to pay it forward with them. Um, Looking back at it, and when I talk to others who maybe are young like me that found out that they had the breast cancer gene, I tell them that if I were to look back and if I were to have done things differently in today's time, because back then when I was 23 and I'm 40 years old right now, nobody was going to operate on me at 23 years old. Like, again, this is like before the Angelina Jolie effect that happened, right? Before all this prophylactic stuff, came into the New York Times and into the media. But if I were to look back on it now, I would tell people, just go. If you know that you have the gene, do the prophylactic surgeries. Like, who cares about breastfeeding? Like, it's okay. It's better to be alive and not to have to go through everything that I went through, and not to, the rest of my life, think, oh, I got a pimple. Oh, I have a headache. I have a stomach ache. Does that mean I have cancer again? Like, it's not good on the brain. I so would have rather have made my decisions differently back in the days. But with that being said, if when I talk to my friends and my breasties about it, if they're not ready for that, that's okay too. But you have to monitor yourself. You have to do all of those the screenings that are available to us. Because that is what I believe truly saved me. So one of my silver linings in my breast cancer journey was knowing that I had the BRCA mutation, because that is what helped me, and that's what found my cancer at an early enough stage, and I was able to gain control. And so I'm trying to think if there's anything else you'd like for me to share about my story. I'm happy to answer questions, or that's it in a nutshell. I was told 4 minutes. I think I did it.
That was great. Thanks so much, Suzanne. We're so lucky to have you, speaking and sharing your story with us. And, we're so many women have benefited from you talking to them and sharing your experience with them and letting them kind of make those decisions on their own. So we're just really grateful, and thank you for being here this morning with us.
You're welcome. Oh, and it's not just about talking with them. I mean, we have like show and feel parties like going on with all these young moms, I mean, because it's really scary. People think, well, what's my body going to look like afterwards? And my best friend will be like, well, Suzanne's boobs look way better than mine, because
I love that. I love that. It's, the open conversation, which goes back to from before, right? Like, we're talking about being open with our families, talking about, our family histories, talking with each other, and just being open. I think that that's so important. And of course, what you're talking about too is advocating for yourself and really getting all of the information. So all of these things are so important, and we're just really grateful that you're here. So thank you. I'm going to turn it over to Bita, it's my pleasure to introduce Bita Nihare. She is a licensed board certified genetic counselor specializing in cancer genetics. She received her master's degree in human genetics and genetic counseling from Stanford University. Ms. Nihare joined the City of Hope Division of Clinical Cancer Genomics in 2012, where she provides cancer genetic services for patients and families suspected to have a hereditary predisposition to cancer. She is fluent in Spanish and Farsi and is committed to advancing the provision of cancer genetics services to medically underserved and culturally diverse populations. And I just want to encourage anybody who has questions to please put them in the chat, and we'll get to them after everybody presents. So thank you.
Right. Thanks so much for that introduction, Jessica, and thanks for your story, Suzanne. I think it's so important to, we're talking about people's lives here, and it's not all science, and so I think it's really important to hear, everyone's perspective and experience. So thanks for that. And I am as Jessica said, a genetic counselor at City of Hope, and why are we here? And that's because while we're all trying to lead healthy lives, right, cancer is unfortunately very common. So about 1 in 8 women will be affected by breast cancer. 1 in 20 individuals will be affected by colon or rectal cancer. And despite that, most of the time cancer is not hereditary. So only about 5 to 10%, or in some cases with certain cancers, 15 to 20% of cancers are due to some sort of hereditary explanation. Most of the time cancer is what we would consider or call sporadic or multifactorial disease, which means that it may have been due to a combination of various factors, environmental factors, other things that we can't necessarily account for. No matter what it is, it's nobody's fault, right? There isn't anything that anyone did to cause this to happen. But the question is, how can we be smarter about being proactive about our health? And that's where myself as a genetic counselor may come into play, and thinking about, what can I do to be more proactive? And so for those of you who are less familiar, genetic counselors, we're master's trained providers, often work with a team of other providers. I work with physicians, I work with nurses, work in partnership with folks like Dr. Smith, who you'll hear about later today, or hear speak, I should say later today, to really help individuals better understand their risk for potential genetic conditions, help order tests and interpret those tests and use that information to improve their health for them as well as their family members. And so part of that is taking the family history. And that's why speaking to your family and having those stories and sharing those conversations is so important, because that's really our first tool in genetics. If you think about it, if we're thinking, okay, is there something that you were born with that predisposes you to cancer or say diabetes or other health conditions? Well, then we expected to see it in our family members as well. But what we're looking for also when we take a family history and seeing, are we suspicious that there may be something genetic going on, specifically are people who have cancer at a young age, like Suzanne had shared, being in her early 30s, so being under age 50 with cancer, having certain patterns of cancer like breast and ovarian cancer, or less common cancers like men having breast cancer like you see here. And so those are sort of red flags or signs that we are looking for to consider, as well as ancestry. And we'll talk about particularly being Ashkenazi Jewish and how that comes into play when we think about inherited cancer predisposition. So once we take a family history, then we consider, okay, is genetic testing indicated here, and have a discussion with that person or the family to determine if genetic testing is right for them. And so a brief review, our genes I like to think of as our own personal blueprint, right? We get half of our genes from our mom, the other half from our dad. So we have 2 copies of every gene. One from each of our parents. And we have a subset of genes in our bodies that I like to think of as cancer fighting genes. So they protect our bodies from developing cancer, like the BRCA1 and 2 or BRCA genes that you probably have heard about and Suzanne shared about. And so hereditary cancer specifically occurs, or an inherited predisposition to cancer occurs when someone has what's called a mutation, or I like to think of as almost like a spelling error in one of the 2 copies of a particular gene. So in this example, you see that, the copy that this person inherited from dad happens to have a mutation. So it's not that you have a bad gene, but just that this person happens to have a change in this gene that causes it not to work. So if this is supposed to protect me from developing cancer and now it's not working, I have one working copy left, but I don't have the same level of protection as I would had I had 2 working copies. And that's why we can see a higher risk for certain types of cancers. And so again, this condition is a higher cancer risk. There are people that carry these gene mutations, live their entire lives, and do not develop cancer. So it's not saying that you will develop cancer or that you have cancer, but more susceptible to cancer. So how can we be smarter about that and thinking about early detection or cancer prevention? And so genetic testing itself is something that can typically for most folks be done with a saliva sample or collecting a blood sample. And what we're doing is a spell check of certain genes in the body to see, again, if you carry a change or a mistake, a mutation on one of the 2 copies of a particular gene, to either sometimes explain someone's personal history of cancer or family history of cancer. And some examples of the genes we look at are the BRCA1 and 2 genes. So these stand for breast cancer gene 1 and breast cancer gene 2, but there are many more cancers that are linked with these particular genes for folks that carry mutations in these genes. And so just as an example, the average woman has about a 10 to 12% risk for breast cancer, but if you're a carrier of a BRCA1 or 2 mutation, that risk is anywhere between 50 to 85%. So significantly higher. Similarly, to get breast cancer a second time, which is why many women, like in Suzanne's circumstance, may consider, having the other breast removed when they're going through breast surgery, or even preventative or risk reducing surgeries like a prophylactic mastectomy. As well as the ovarian cancer risk. But these genes also, and mutations in these genes impact men. So it's just as important to be thinking about your dad's side of the family or men in your family, like your brothers, your sons, your father, uncles, and others, cousins, because there is risk for men to develop breast cancer, prostate cancer, and then both men and women can be impacted by pancreatic cancer. And so, as Jessica was saying, Ashkenazi Jewish individuals specifically have an increased risk to carry these particular gene mutations. And really about 1 in 4 or 500 people, if you're thinking about across the globe, will carry a mutation in the BRCA genes, but it's about a 10-fold risk higher if you're of Ashkenazi Jewish descent. And that's why, our threshold for when we think about genetic testing for people who are Ashkenazi Jewish is also much lower. And the reason that it's more frequent is because of what we call a founder effect. So if you think about, our ancestries and how that plays into genetics, right? You think about particularly for, Jews in the diaspora and pogroms and other things that have happened over the course of history. And, have significantly lost, a significant portion of the population because of that, past trauma, that past history. Over time, what happens is we have sort of an increase in the frequency of some of these genetic changes. And so that's why we see a higher frequency in people who are Ashkenazi Jewish. And we can see that also with other ancestral groups. So it is important to note if you're, say, Sephardi or Mizrahi Jewish as well, your ancestry, or if you're not Jewish, your ancestry is important. So speaking to anyone who has a family history of cancer or personal history of cancer is important. And beyond that, there are more than just the BRCA genes like Jessica spoke to. And so oftentimes when we do genetic testing, we're looking at a whole subset of genes as a multi-gene panel, like the ATM and CHEK2 genes that she had mentioned. And there's still a lot that we need to understand about the genetics of breast cancer or other types of cancers. So this is just one example of types of genes with breast cancer, but you can see the same with, say, colon or uterine or ovarian or prostate cancer. And so speaking to a healthcare provider about, what the best option for you is what I would encourage anyone to do. And, each gene is not the same. So, when you're considering testing, it's important to realize that the risks for cancers vary from gene to gene. Not all have high risk where we might consider preventative surgeries. And maybe it's just doing more frequent screening or the types of cancers. And so BRCA, for example, has breast and ovarian cancer risk, but another gene, it might be breast and uterine cancer. So understanding that there are varying cancer risks. Most genes will cause an increased risk for cancer in adulthood. Very rarely do we see it in increasing cancer in children. So things like that to consider. And then the recommendations will vary because of that. So I mentioned earlier, there are different types of genetic tests, and this is where a genetic counselor or a genetics provider or your healthcare provider you're meeting with can help you decide. So if we happen to know that there already is a mutation in the family, some people will just get tested for that mutation. People who are Ashkenazi Jewish may get tested for the 3 common founder mutations. People who are focused on a particular condition may just get tested for a single gene. But by and large, I would say more and more people now are getting tested by way of what's called a multi-gene panel, where we are looking through multiple genes, maybe across different types of cancers, to see if we can find a particular gene mutation. And there are many different reasons why you may select one versus the other, but most are done in the same fashion where it's a saliva or a blood sample. And there are different types of genetic test results. And so that's where talking to someone in advance of doing testing can be helpful to understand that. So you may get a negative test result, meaning that a mutation wasn't found. And it's important to understand that that doesn't mean that there's no cancer risk. It just means that we haven't found a genetic explanation with the testing we've done so far. There could be, on the other end of the spectrum, a positive test result, meaning we found a mutation. So we found some sort of genetic change that increases cancer risk. Or sometimes we come across these uncertain changes that at this point, we don't know if they are associated with an increased cancer risk. And so my job as a genetic counselor or your healthcare provider ordering the test, will hopefully be keeping an eye on this to see if we can get updates over time to learn what these types of changes mean. And so, beyond thinking about, knowledge is power, beyond thinking about why, we may do genetic testing. So having, knowing about the option of preventative surgeries to reduce your cancer risk is one that we've talked about, or doing screening at a younger age or more frequently to catch cancer early is another consideration. For folks that have cancer, so, Dr. Smith's area of expertise, right? It can also be helpful in thinking about certain targeted therapies or modifying, say, chemotherapy for people who are actively in cancer treatment. And then for the benefit of the family, right? Because we're hoping to change the legacy of cancer in families by knowing about this in advance so that we can catch things early and folks don't have to continue to go through maybe the experiences that their family members did. And, typically, if you do carry mutation, as Jessica mentioned, there's a 50% chance that your brothers or sisters, your sons or daughters may also carry this genetic change because of how we pass on our genes to our children. All right. And so this is a very busy slide, but also just has some information that a lot of folks ask about, how do I get tested or when should I get tested? And I think that the first step is really just talking to maybe your primary care provider and, talking to them about your family history to think about sort of the best approach. So that can be done that way, talking to a genetics provider like myself. There are tests available that we call sort of direct to consumer or direct access. And it's just really important to know the limitations of these types of tests. Like 23andMe is not a genetic test that's really going to do a good job at assessing your cancer risk. So just knowing about the limitations and what a test can and can't tell you is going to be really important. Most of the time we're recommending people to get tested in adulthood. But if you have really young cancers in your family, then it's important to talk to your provider about that to see if we would modify when we offer testing. And these days, more and more genetic testing is covered by insurance, or at least is becoming more affordable as we're increasing access to care. So it can be as little as a couple $100. It still can be on the more expensive side, sometimes depending on certain tests. But that's, again, a discussion you can have with the provider and then determine if testing is something you're comfortable with and can move forward with. And, and there are now, there's legislation and laws that protect against some forms of genetic discrimination. So, getting tested now is very different than, say, getting tested 20 years ago when people were more concerned, because we have more and more of these protections. And there are resources I'm happy to share if you have more questions about that, like the Cancer Legal Resource Center. And I'm sure Sharsheret has great resources to talk to people about that. So there's information out there if you need it. And so with that, I will wrap up, and I think we have some time allotted later for questions, but happy to answer anything as well in the chat. Thanks.
Thank you so much. That was great. It's always so important to learn all about all of these different, about the genetic components. And sometimes I think we have that like 7th grade or high school memories of what genetics are. it's so important to have that refresh of like, oh yeah, this is how it passes down and this is what I need to be concerned of. So I'm really grateful. Thank you for being here. And now I'm going to turn it over to Dr. Wade Smith. Dr. Smith is a board certified medical oncologist and assistant clinical professor in the Department of Medical Oncology and Therapeutics Research at City of Hope, Orange County. He has expertise and training in a variety of cancers. Dr. Smith cites a lifelong fascination with biology that has led to work exploring immunotherapy to treat chemotherapy-resistant cancers, particularly breast cancer. After completing his Bachelor of Science degree in biology at Loyola Marymount University in Los Angeles, Dr. Smith received his MD at the Creighton School of Medicine at Creighton University Medical Center in Omaha, Nebraska, before completing his residency at Emory University School of Medicine in Atlanta and a fellowship at its Winship Cancer Institute. He then relocated back to Southern California to continue his career in medical oncology. Welcome, Dr. Smith.
Thank you, Jessica. Can everybody hear me okay?
Yes.
Yes.
Okay, great, thank you. Well, I'll add some to what Beta has been able to articulate very effectively, and then just give my own perspective as an oncologist who treats breast cancer, who also treats ovarian cancer, and who is also involved with a high-risk screening program here that we have. But I think my fascination and interest in pursuit of this really began in medical school. I had an opportunity to work with a gentleman named Dr. Henry Lynch, who kind of became known as the father of cancer genetics, based upon the fact that he was really the first to identify back in the early 1970s that cancer had a hereditary pattern of spread that was really controversial at the time. He had great difficulty finding NCI funding behind any of his research projects. And what he did was he had a van and he would drive around the Midwest doing pedigree analyses on large Mennonite communities and detecting that there was in fact various hereditary cancer patterns, and one of which would lend his name to the Lynch syndrome, which is a colorectal cancer that also involves ovarian cancer and other GI cancers. But even back in the early 1970s, he was identifying hereditary breast and ovarian cancer patterns that were, 20 years before the BRCA1 gene was detected by Dr. King at Berkeley. So, I guess the point being is that we're very early into this whole idea of being able to risk stratify people based upon genes they inherit from their families. And as such, I know there are some questions about, where is the future going? What will we have for our daughters? And in my opinion, and I'm sure Beta would agree, it's going to be in testing for hereditary cancer syndromes and finding out who carries what gene and at what risk does that gene put that patient at. So I received an interesting, very good list of questions that I can go through, and also field some additional questions. Whenever I have a chance to address a group, though, I like to kind of impart a couple insights that I have with regard to my own experience. And I thank everyone. I thank Suzanne for sharing her story. I thank everyone here for being involved. And I would say that as a community of survivors and people who want to be involved, there are some things we should watch for. And I will say that as a primarily breast dedicated oncologist, I see with alarming regularity, probably every couple months, a woman come through the door who has a large neglected breast cancer, something that anybody would be able to almost, see through a blouse, but has done a very good job at concealing that neglected breast cancer over a period of months, sometimes a year. And these are typically women who are very high functioning career women who type A personalities, who have an extraordinary ability to compartmentalize and keep things from their spouse, their partner, not talk about things among their circle of friends. And so it's always been of interest to me to find out how do we find that person that comes through the door every month to 2 months, to catch her early on. And I think part of that has to do with screening, I believe. You know, there's been called into question whether physicians should be doing annual clinical breast exams. You know, is there really data to show that it saves lives? Well, for one, I think it helps to interface with that patient to say, you know, somebody does care about something that you may be hiding. You know, so it is important to have your annual visit, and it's important for her friends and contacts to ask, you know, have you had your screening mammogram? Have you had your clinical breast exam? And so that I will soapbox on. And then I will also say I also see with some regularity patients who seek out at time of early diagnosis alternative medicines and integrative medicines, and that's something that should be watched for too, or that seek out really suboptimal or completely ineffective means of screening. You know, thermography is not acceptable to have a thermogram every year for detecting breast cancer. Every woman, in my opinion, needs a mammogram at some frequency starting at a certain age. And so again, on occasion, I will have patients come through the door that have an advanced breast cancer, and the only practitioners they've seen have been, you know, alternative medicine doctors. And not to cast a light on all integrative therapists. We have a great, you know, cooperation with many integrative clinicians and therapists in the community that work alongside doctors that, you know, do the responsible thing and bring attention where it belongs. So touching upon that, I think I'll just jump into the questions, and anyone can just jump in if I'm not answering it to their satisfaction. But you know, great questions. You know, what are the screening guidelines for women based on age? And that's been an area of controversy. You know, 40 versus 50, annual versus every 2 years. And I think a lot of it comes down to, you know, what is the cost at lives saved? And what is the duress to the patient? You know, how many patients are having to go in for unnecessary biopsies and so forth. So what I will say is I'm a proponent of starting at 40, and I'm a proponent at annual mammography. And so I pretty much start the conversation with that. And I think it is important to feel out on the part of the patient, you know, where there might be reservation. Maybe there's a lot of anticipatory anxiety that patients live with, and that they otherwise have a very kind of low background risk for developing a breast cancer. You know, that may be somebody to start at 45. And then, you know, likewise, someone who travels, who's out of the country a lot, looking at an every other year mammogram for some time being, you know, I'll have that discussion with them. But kind of as my default recommendation, I do recommend mammography at 40 annually, continuing all the way through to age 75 and beyond if they have a 10-year life expectancy or greater. And if I'm starting to run out of time, let me know also. But you know, men, yes, breast cancer affects men less frequently, 1 in 1,000. From an Ashkenazi Jewish community perspective, obviously, men who are carriers of BRCA1 and 2 have a higher risk of breast cancer. Do we screen these men? We don't typically screen these men, with the exception if they do have gynecomastia or glandular breast tissue. A discussion can be had about mammography for patients that may have a particularly high risk. But by and large, we're not screening these men, but we are basically advocating the same that we advocate for women, which is just awareness, self-awareness. If you detect anything at the nipple, skin, deep, that's new, seek attention right away and have it worked up. And then, you know, what's the latest in ovarian cancer screening? With respect to, with regard to the Ashkenazi community and BRCA testing, I will say there's really no good effective ovarian cancer screening to date. And so, you know, that really gets to the point of risk stratification and finding out what your lifetime risk of ovarian cancer is. And that comes from, you know, family history. And certainly if you are found to have one of these mutations, certainly BRCA1, BRCA2, even, you know, there are BRIP1 and RAD51C and D, other mutations that may put a woman at particularly high risk of ovarian cancer. We really do advocate to have the ovaries and fallopian tubes removed, because that really is the only intervention that has been shown to have a survival benefit. Ultrasound, testing CA125 really hasn't been nailed down as having a survival benefit. So I would argue that. And relationship between age and cancer, as we get older, our risk of cancer increases. So You know, I would say, again, the importance for mammography, continuing all the way through. And then what's the latest research on hormone replacement therapy? That's a good question. Based on the WHI study, the large study several years ago, there was a more recent large meta-analysis in 2019. Basically, there is risk. There is risk for breast cancer by taking hormone replacement, particularly combining estrogen and progestins, puts women at increased risk. I think that it's really hard to nail down what that exact risk is because modern preparations are a little bit different than that which we know from these large studies. But there is a measurable risk. I think any woman should certainly consult with their provider and have some form of risk stratification before deciding that that's what they need to pursue for reason of severe menopause related side effects and issues. How do I perform a self-breast exam correctly? That's a great question. I will say area of controversy also, because you'll hear many experts saying there is no survival benefit for women who do self-examination. And so as such, a lot of the panels are recommending just more self-awareness. I would say that for women who wish to be proactive, once a month in the shower, kind of a routine. Basically, you're not searching for a lump, and that's where women get frustrated. They say, "I've got really lumpy breasts. I get frustrated and anxious every time I do it." You're basically just feeling for anything that stands out, and have a low threshold for having it evaluated. And so for those who are wishing to be proactive, I feel once a month is reasonable. And when should I be concerned about irregular periods? Depends on if you're premenopause or menopause. Really, abnormal uterine bleeding always has to be evaluated regardless, but certainly in a postmenopause woman having abnormal bleeding, you should seek to be evaluated to determine the cause, as well as premenopause women also. And then, I think Beta answered the question about genetic test kits. I think, our own experiences in recent few years, expanded panel testing has become affordable like it hadn't been prior to some recent court decisions. So women can go out and get a comprehensive expanded panel test for a few $100s if their insurance is not covering it. So I would say, and that leads into this other really good question: should all people be genetic tested? I think that that is a question that I think again has a lot to do with family history as well as your overall background risk. I think that knowledge is power. I think that I think every patient should be made aware of what the implication of having genetic testing is. And so they should have the discussion with their provider. They should know they may have a mutation that is a variant of undetermined significance. We don't know what it is, so we'll continue to monitor it. That actually can be a source of anxiety for some patients. Is this real? Do I need to react? So forth. And then, patients of different, as had been mentioned, of different backgrounds, hereditary backgrounds, Asian, Central Asian, they may have founder effect mutations that we're not testing for. And so that's something that we need to be aware of too. Patients may have gene testing done with an unsatisfactory reporting. And there are basically online calculators that can be used to assess a woman's risk outside of what their gene testing shows. And by and large, if we feel a woman has a lifetime breast cancer risk of 20 to 25% or higher, we are aggressive in terms of screening for those patients. We will advocate for many of these patients to have annual MRIs to complement their mammograms. And in terms of I think when to start screening, again, for those patients that are high risk, either they had a high risk come out on one of these calculators like BRCA Pro or one of the others, or are carrying a known high risk gene mutation. It really depends upon the mutation. So for instance, many are advocating if you have a mutation called ATM or CHEK2 to start MRI screening at age 40, whereas if you have a mutation such as PALB2 or NF1, start MRI screening at 30. So I think the key understanding to that is, if you know you're high risk, it is very good to get in, meet with a genetic counselor, determine exactly where you're at, have that expanded panel test if indicated, and then that will help us determine what the best screening strategy is.
Thank you, Dr. Smith. This has all been really, really informative. I'm gonna also add Vita there as a spotlight. No, we can ask a couple of questions. One of the questions that came in the chat is, does original Medicare plus supplemental plan cover genetic testing for anyone of Ashkenazi descent, or do you need to show that you have close relatives who have had cancer? Vita, do you want to answer that?
Yeah, so, and that's a really great question and brings to a lot of things. So a lot of points I think that are important. And so there are folks now that are advocating, like Dr. King, who helped, identify BRCA1 in the 1990s, who advocate for, let's just test all women, regardless of family history, starting at age 30 for BRCA1 and 2 because of its, potential benefit. And a lot of debate within the community, a lot of debate about whether or not our healthcare system can sustain testing that many people, right? And so then there are then places like Israel where they test all folks, because there's a high Ashkenazi Jewish population, or some of these other groups with founder mutations like, Arab Israelis, Sephardi Jews, et cetera, for more common mutations that we find across the population. Also, because if you think about it, many folks who are of Ashkenazi Jewish descent have lost a lot of their family members to the Holocaust. So there's also family history that's lost there as well. But there aren't any current consensus guidelines that say, yes, if you're Ashkenazi Jewish, regardless of any family history, we recommend testing. It's more of a consideration. And I would say because of that, insurance companies haven't quite yet picked up on that. And so typically, if you are Ashkenazi Jewish, you need to have either a family history or a personal history, something like that for your insurance to cover it. Medicare is also nuanced in that Medicare, because of its original charter and its purpose, doesn't cover genetic testing for people who don't have a personal history of cancer. So for like BRCA testing, you need to have breast cancer or ovarian or pancreatic or prostate cancer. That being said, meeting with a genetics provider or someone who's more skilled can also figure out other sort of tools or tricks to get testing at an affordable cost, or in some cases free, knowing about, say, laboratory programs. There are research studies like the Before study that's looking at BRCA mutations in Ashkenazi Jewish people. So there are different ways to sort of get, creative to figure out how to get testing covered. So I would say always ask, don't assume, because there are so many resources out there. And even City of Hope, actually, right now, we have, acknowledging the importance of genetic testing, we have a research study where we're offering genetic testing to all patients. So that's expanding, throughout all of our clinic sites as well. So there are many ways to get tested, even if your insurance doesn't cover it.
Great. I wanted to just touch upon a couple of things because I know we're running out of time, and we have Susan's presentation on the City of Hope expansion. I wanted to just touch, Dr. Smith, you had how genetic testing influences treatment plans for women who might be, or patients who are diagnosed with cancer.
That's a great question. So I can say specific to breast cancer, certainly carrying a BRCA mutation, for instance, we know can impact treatment decision-making, particularly in the metastatic setting. So certainly, we have the availability of what's called a PARP inhibitor to treat women that are carriers of this mutation that have an advanced breast cancer, and this is a tolerable class of drug that has been shown to be highly effective, and we integrate that early on in their treatment course when we know that. So that's important. There's even a trend in thinking that treating patients in the early stage setting can be impacted by knowing that, by having that information. For instance, sensitivity to platinum drugs, a type of chemotherapy we use in the early stage setting, may be influenced. That decision making may be influenced for some.
Thank you. And then last question, which I guess is might be sort of for both of you. When somebody, I've heard when people are diagnosed, sometimes they say, well, why do I need genetic testing now? So I imagine the answer to that would be part of what you just described. The other question that brings up is retesting. So if somebody has had genetic testing done, and let's say in the early 2000s, is there a reason that they should be getting tested again? Does that make sense? How do you look at that?
Yeah, I'm happy to answer that. And yeah, Dr. Smith, you can weigh in too from your perspective. Absolutely. We generally also encourage people to check back in every few years because of the advances in genetic technologies, or because family histories are dynamic, right? What is going on right now could be very different a year from now, 5 years from now, 10 years from now. And we're getting smarter about, how to do screening and other things. So it's not always then to definitely do testing, but it could be discussions about better screening tools or modifying screening or whatever it may be. I generally, the answer is yes, particularly if you've been tested prior to 2015, because I think that's when really multi-gene panels were becoming much more standard of care. And especially if you're Ashkenazi Jewish, many times the testing was just limited to those 3 founder mutations, or the technologies in about 2006 to 2007 changed for BRCA. So if, your family history is still, personal or family history is still unexplained, if there are new cancers in your family, if you're particularly young with cancer, have less common cancers, I think it's just good to have a discussion and say, hey, should I be getting updated genetic testing, and then considering something like a panel.
Yeah, that's my understanding too. I think inflection points in time would be 2006, prior to 2006, prior to 2016. Certainly, for a patient newly diagnosed, we do expanded panel testing, as opposed to BRCA limited for cancer patients. Also noted, patients who are carriers of BRCA1 or 2 will often opt to have a bilateral mastectomy at time of surgery too. So we do rapid testing at very onset of diagnosis, because that will obviously impact surgical decision making.
Thank you. Thank you both. Beta, did you want to add something? Or?
Yeah, just something else that I wanted to add that I didn't touch on. The other reason for these, we're talking about changes that can increase, cancer risk, typically in adulthood. This information can also be extremely valuable for some people for family planning, because, some people want to know in advance of, say, having children, to know if their partner also is a carrier of something. Where I talked about, if you only have one BRCA mutation, but there are circumstances where if you have, say, 2 BRCA mutations or 2 Lynch syndrome associated mutations, it can cause different genetic conditions. So I think it's also just important to know, when you're either, early adulthood, thinking about family history and screening, but then also thinking about a family, are all good time points to be thinking about this as well. So I'll stop there.
Thank you so much. We're all so grateful for both of you and sharing your expertise on this, and really such important information for all of us to be knowing. I'm going to turn it over to Susan Fox. Susan has been instrumental in launching the City of Hope's City of Hope expansion into Orange County. And as the Senior Physician Relations Liaison, Susan's role is to partner the community physicians to help facilitate patient care through education about City of Hope's internationally renowned expert care, now available to our local community members in Newport Beach, and providing updates on the Irvine Comprehensive Cancer Center, which will be opening in August 2022, and assisting with patient access. So Susan, I'll turn it over to you.
Well, thank you, Jessica, and the rest of the panel, and Suzanne, particularly for sharing your own personal story. Those are always so dynamic to me, and really impresses upon everybody to your own best advocate for your health. So I think, and you sharing your story with other friends is always just really amazing. You guys are my heroes. So with that, I wanted to share a little bit about City of Hope and our expansion to Orange County. So I have a slide presentation, and at the end I have a short video that takes you on a tour through our Newport Beach facility. But it's so exciting to be part of this expansion. And essentially we're building a mini Duarte. If you all are familiar with City of Hope Duarte campus, then I'll share with you what we're doing down here in the Irvine area. So thank you very much. I think we're going here. And okay. Can everybody see my screen?
Yes.
Okay, yeah. Well, again, I want to thank you for coming. And this I found really interesting when I learned this. City of Hope actually was established with 2 tents in Duarte in over 108 years ago, 1913. By the garment district workers whose co-workers had tuberculosis. So they put a couple tents out in Duarte and started caring for those patients out there. And that's kind of how our compassionate care and our love of helping our community members has started. So in 1948 or so, they found a cure for tuberculosis. And then our mission became something kind of minor, like trying to eliminate cancer and diabetes. So that's been our mission since the late 1940s. And the amazing thing that we have to offer at City of Hope is that millions of people worldwide have benefited from the research that we have done on our campus. We have more than 500 clinical trials going on right now, over 1,000 scientists and researchers that work on that every day. And we're expanding those clinical trials into Newport, and we'll have extensive research going on in Irvine, which I'll share in a little bit as well. But some of the breakthroughs that we have done are, the drugs that are impacting so many people's lives are the Herceptin, Erbitux, Rituxan, Avastin, and all this, many other technologies and drugs have been developed through our research there. We're also leading in the country on CAR T-cell and bone marrow transplant. So we have a huge history of advanced treatments and technologies. And the other thing that we have at Duarte, we have 3 manufacturing plants. So if we find something that is working in our clinical trials, then we can manufacture that product or that drug and get it to our patients very, very quickly, much faster than normal cancer institutes. So why are we expanding into Orange County? We have 20% of people in Orange County that are diagnosed with cancer leave the area. And so, and about 4,000 of those patients were actually going to City of Hope. They're also expecting an increase of 20% growth of cancer by 2030. And when we looked at all that analysis, it was decided that we really needed to expand and bring our advanced treatments and research into Orange County, so that Orange County residents will have access to the type of care that we're able to give into at Duarte, and they can have their care closer to home. They don't have to travel to Duarte or LA or San Diego or even out of the state. So this picture shows some of our cancer patients from Orange County who have been making that trip all the way up to Duarte, and how grateful they are that we have these resources now down here in Orange County. They're just wonderful advocates for our organization and beautiful people. So I wanted to show you a little bit about Newport Beach. Was our first facility here in Orange County, and it opened in January of last year. A lot of people don't know that we're here and we're available to your patients in Orange County. We're located over near Fashion Island and have highly specialized medical hematology and oncology surgeons, and our infusion center. You can see a little bit of a snapshot, and I'll do a tour a little bit later, a virtual tour, a full service infusion center with our immunotherapy, chemotherapy, and other IV type of therapies available. We have a survivorship and support program there as well. We have an on-site licensed social worker who is there to help our patients as they're going through treatment or recently got a diagnosis. Melissa's wonderful and has all kinds of resources, and was thrilled to hear that we were working with the Charcheret organization as well. And we recently in January launched a lung cancer screening program as well, finding that that's the leading cause of cancer in Orange County, or actually the world, and really want to address that at an early stage as well. So Irvine, which is, going to be the hub of our expansion into Orange County, we actually purchased this building. It's a 190,000 square foot building in the 5 Points there at Barranca and Alton in Irvine. And it's going to be an outpatient center that will have surgery, everything from preventative medicine to clinical research, our phase 1 through 3 trials, surgeries, all the resources that you need. We'll have some genetic testing down there as well, Beta, and just really very, very comprehensive. And that's scheduled to be open in August of this next year of 2022. And then the exciting thing is on the end of it here, we're going to, right here on the end of this one, we're attaching a 6-story cancer specific hospital. That started out to be a 4-story hospital, but in again, the research and the demand that we're seeing, we felt like it was best to go ahead and add the extra 2 stories so we can accommodate those cancer patients as the need does in fact grow here in Orange County. So just like I said, we're building a mini Duarte down here in Orange County, and just really excited about being able to have greater access to our patients here in Orange County to our services. These are physicians that are currently in Newport Beach. And besides Dr. Smith here, you can see Dr. Hang Dang is our surgical breast oncologist. And then Linda Buck also is our nurse practitioner who has an expertise in breast cancer and actually is a breast cancer survivor herself. So she's very empathetic and knows what these patients are going through, and has a lot to share with them as well. But as you can see, we can accommodate any cancer and hematological issues that our patients may have here in Orange County. And then I'll skip that and we'll go to the questions later. But here's our Newport Beach facility. We'll just zoom through it real quickly here. It's, as I mentioned, it's in the Fashion Island area. It's right across from the Metro bus station there. But we designed the building, redesigned the building when we took it over to make it as soothing, as patient-centric as possible, but as calming and relaxing for our patients when they do join us. This is one of our exam rooms. So we have, I think it's 7 exam rooms, and then our infusions upstairs. We can have private rooms, or some of our patients like to come and kind of have a, I don't want to call it a coffee clutch, but they come together at the same time. So, because they get to know each other, they're there every week doing their treatments. And so they really latched onto that during COVID. It was kind of a social hour for them to get together. So again, you can see the design that we made to make it very soothing and relaxing for our patients. And then this is the our nursing station. And let's see, we'll keep going through here. Some of the infusion chairs actually have views of the ocean. So it's all bright and light for the patients. We also had one of our grateful patients worked with a local artist to bring in custom commissioned to have artwork put in the facility here to add to the effect of the the relaxation and such. So I'm trying to, this is our check-in. You don't see it in this picture, but we also have a small wishing tree there. And we're known for our wishing tree up in Duarte. We have 6 of them, and you can tie a little tag on it and put your wish on there. It's a Japanese tradition, and then that wish will then come true as the wind blows through it. So we're transplanting a couple of those wishing trees down to the Orange County campus as well. So thank you so much for letting me share that, and I'll turn it back over to Jessica.
Thank you, Susan. That was really great. The facility looks like it's going to be amazing, and just, I think, like Bita said, so very light and bright and just beautiful.
Yeah.
I wanted to thank everybody for being here today and for joining us. I hope that you learned something I know that I did. Thank you, Dr. Smith and Bita and Suzanne for sharing your story. Jerry for planning everything. I'll turn it back over to you, Jerry. If you have any questions about Share, please feel free to email me. I'll put my email in the chat. I'm also going to send up a follow-up email that Jerry can send to all of the registrants so that they can see that. And of course, we've recorded this, so hopefully that will be available as well. So
yeah, this recording.